Dear friends and colleagues, there is the bubbling enthusiasm of Dr. Gautam Zaveri, Kshitij Chaudhary, and the entire ASSI executive that has kept us agile and academically alive during this horrible pandemic. I congratulate them for their constant endeavor to keep the flame of academics alive during this period. And one of the endeavors has been this very popular and prestigious journal club. I would like to thank Dr. Gautam Zaveri and Kshitij for this kind invitation to contribute to this journal club series. It is indeed a matter of prestige. On the contrary, I may not really conform to this theme of presentation, wherein I need to discuss the papers that have shaped me, because the vast majority of knowledge that I use in day-to-day practice comes from what I have absorbed from my mentors during my training. And I was very fortunate to have exceptionally great mentors. What rubbed on to me from them in terms of decision making, execution, etc., stemmed from their understanding of the subject. And when I go to those depths as to why they decided to do a particular procedure and what was the background behind that decision making, then there are certain papers that strike me, and most of them deal with biomechanics, because basically spine goes back to its basics of orthopedics, and orthopedics relates to biomechanics. So these are the few papers that I have drawn, which continue to have an impact on me when it comes to patient management in day-to-day practice. Apart from that, there are a few miscellaneous papers that have modified my practice in the last few years. So the striking paper that influenced me right in the beginning of my training was this particular paper from the Hong Kong group, which is totally a group of outliers. They think differently. They have established new norms in spine surgery. So this concept of vertical instability in spondylolisthesis cleared a lot of doubts in the earlier part of my training. I was to wonder what is the basis of doing an interbody fusion in spondylolisthesis. How would what was the background behind spondylolytic spondylolisthesis? What is the biomechanics of degenerative spondylolisthesis? This paper cleared all my doubts. So in this particular paper, the authors consider the intervertebral disc to be an intact flag post which is surrounded by cables or the ligaments under tension. They also compare this with an inflated balloon. So when the flag post is fractured or when the balloon is punctured, this is similar to a disc that is degenerated, which loses its turgidity. The cables, in case of the flag post, or the ligaments, in case of the intervertebral disc, get slack, and this allows translational displacements. So this is the basic fundamentals with regards to the manifestation of a slip in spondylolisthesis. So in degenerative spondylolisthesis, it is an inflated balloon that collapses and then translates. And in case of spondylolytic listhesis, it is the failure with the posterior tension band in terms of the lytic component that causes stress on the disc, causes it to degenerate, leads it to degenerate, and that degeneration in turn leads to a translational displacement. So this kind of slackening of that particular segment leads to collapse of the disc, which is very volatile. It is a viscoelastic property of the segment which allows it to collapse. But again, in certain positions, it can open up. For example, in this particular position, you can see that it is a collapsed L4-5 disc as a result of a degenerative listhesis. But there is a potential mobility in this particular segment which is causing the instability, and that is very well shown in this MRI, which is usually done in a supine position. So the hypointense lesion seen in the disc space at L4-5 in a T1 weighted image shows a vacuum which basically represents vertical instability, and this kind of patients need an interbody fusion. Similarly, another patient with an occult collapse, which is not very evident on a standing flexion extension X-rays, becomes evident on positioning the patient on table. So this is vertical instability. This concept helps in understanding many pathologies. Another example of a L5 S1 spondylolytic listhesis showing the potential instability within the segment as a result of vertical instability. So this understanding of the concept always runs in my mind when I evaluate a patient. For example, this was a patient with spondyloptosis who wanted a minimal access spine surgery to reduce the segment and fix it. What my rescue? In such a situation which almost looked impossible is this concept of vertical instability. As the patient was positioned on table under anesthesia, I could see that the disc space was opening up. So this is vertical instability, and it gives an understanding of the fact that the ligaments are loose, there is less annular tension, and this causes mobility in the segment, and this can be exploited to get a reduction as was achieved in this patient, and forms the basis of this paper based on this particular report. So basically, vertical instability is an important concept. Disc degeneration, either primary, de novo, or secondary to a structural abnormality such as spondylolytic spondylolisthesis, triggers vertical instability. And this can happen at any level, lumbar, cervical, or thoracic regions. And this forms the core of most symptomatic degenerative conditions. For example, lack of annular tension causing discogenic leg pain on loading, degenerative spondylolisthesis, spondylolytic spondylolisthesis, degenerative scoliosis, etc. The next paper is one where it is an excellent example of learning from failures. I find it a very interesting concept. So this is an example drawn from the same paper. This is a 62-year-old lady underwent a 2-level corpectomy at C5, C6 and an anterior fusion with cage and a plate from C4 to C7. This is the post-operative lateral radiograph after 2 weeks. Everything looks quite intact. Within 6 weeks, you can see there is movement happening there. The screw is pushed down, the cage is subsided, and in the next image, that is picture C, you can see that there is complete subsidence of the cage to the end plate of C7, and the screw has plowed itself into the disc space at C7 T1. Why did this happen? In a 70-year-old male with a cervical spondylotic myelopathy who underwent a corpectomy at one level and reconstruction with cage and a fibular graft at a lower segment, and this was plated. And over a period of time, you can see that there was subsidence superiorly into C4 body, and there was complete subsidence at the end of 9 weeks with further collapse. Why did this happen again? So this particular author went ahead and studied these cases which were managed with tall mesh cages and anterior cervical plates in reconstruction of cervical spine following corpectomy. So there were 23 patients in this particular study. 15 of them had undergone a one-level corpectomy, followed by reconstruction with titanium mesh cage and a plate. And there were 6 patients who had a two-level corpectomy, treated similar wise, and there were 2 patients who had three-level corpectomy, who were again treated similarly with a titanium mesh cage and a tall anterior titanium. So interestingly, almost everyone from the 3-level group and a large majority from the 2-level group and a minority from 1-level group had a complication in terms of the cage kicking out and the plate, in terms of plate kicking out and the cage pistoning. So why did this happen? Why did this complication occur at the first place? So this will drive us back to a research paper that was published 5 years earlier by this particular group, which compared the stability of a strut graft versus a strut graft with a plate two-level corpectomy model. So let me pull you down to this particular conclusion of the study. So what it showed was a strut graft without an instrumented apparatus is loaded in flexion and is unloaded in extension, whereas a strut graft with an anterior plate runs contrary, so that is loaded in extension and gets unloaded in flexion. So this can cause pain. So the conclusion of this particular study was that the plated construct is biomechanically superior to a strut graft alone because it decreased the local motion significantly. However, the strut graft is stable in flexion and unstable in extension, while the anterior plate reverses this loading pattern. So it loads the graft in extension. So when in flexion, there is a possibility of pistoning, and this can cause construct failure. And what has been recommended for such a situation where you're replacing 2-level or 3-level corpectomy with a cage and a mesh plate is that you should always supplement this with a posterior fixation to recreate the posterior tension band to allow it to be stable in flexion. This particular paper impressed me and influenced me substantially. It made me a thinker when discussion came down to the point of stabilization. It demonstrated the power of posterior column, the say the posterior column has in the integrity and stability of the spine. It pushed me to not settle for a satisfactory construct, but aim for a rigid construct irrespective of the region or the junction. Now, this is the third paper which I'll be talking about, which has influenced me. This is about fixation at the lumbosacral region and the concept of lumbosacral point. So fixation across lumbosacral junction is a challenging proposal for anybody because of poor bone quality, osteoporosis, complex regional anatomy, highest level of transitional shear stress at this region, because alpha S1 disc bears the largest summation of vectors in all planes, and because of poor experience in terms of high pseudoarthrosis rates and implant failure. This paper comes out from a highly reputed group in terms of biomechanical experiments are concerned. As far as biomechanical experiments are concerned, Cunningham et al. So the aim of this study was to determine if all fixation devices that cross SI joint were equally stable. This was purely an experimental, animal experimental study. And the models which were considered were divided into iliac, S2, S1, which were compared against no intervention. So how was the study conducted? A flexion movement was applied And the parameters which are noted was applied moment, degree of flexion, strain, mode of failure, purchase site of lumbosacral fixation device, and extensometric values at L5S1. So what was found was the crossing the SI joint is justified biomechanically only when fixation extends anterior to the pivot point. And what is the pivot point? It is the intersection of the middle osteoligamentous complex and L5S1 disc space. It was found that iliac fixation demonstrated the maximum moment, maximum stiffness, maximum strain, and minimal bending at failure. So with this study, the authors came to realize the concept of a lumbosacral pivot point. So this is the axis about which the lumbosacral spine rotates. There are large cantilever loads that exist at this particular region, quite obviously. And it's mainly on the middle column that these forces act. And it is recommended based on the outcomes of this study that the iliac screws are the longest and they help in extending fixation beyond the pivot point and thus help increase the strength of the construct. This has been a versatile axis and approach and anchor in most of my surgeries. So whenever in doubt, I go to the pelvis, and this has been my mantra. And I really get a peaceful sleep because I face minimal failure rates in long fusions where I cross this particular junction and put screws in ilium and extend my construct. And definitely the kind of lesions that we face in the lumbosacral region, whether it is tuberculosis, whether it is tumors, or whether it is failed surgeries, it delivers its goods in terms of better outcomes. For example, this was, S1 tuberculosis, where the entire S1 vertebra had got destroyed, and the patient was bedridden for months together. And what came to our rescue was these iliac screws to help the patient become mobile ASAP. And this was derived from the concept of lumbopelvic fixation for sacral fracture dislocations. So the next interesting paper that I would discuss about would be this very popular paper by McCormack and Gaines. I really thank Gaines for this particular publication. So I find it to be a landmark paper, and again, another illustration of learning from failures. The advent of pedicle screws enabled preservation of motion segments in spine instrumentation by aiding short segment instrumentation and fusion from posterior approach. So pedicle screws came like a hurricane and washed away all other implants. They gave the surgeon a superior confidence in instrumenting spine, wherein with overconfidence, we started doing a short segment fusion, and this led to implant failures, loss of correction, etc. So based on this concept, the authors derived this load sharing where, the failure of construct was measured against the degree of destruction of the anterior column, which was in turn based on the degree of comminution, how opposed the fragments were, and the degree of kyphosis that needed correction. So basically, it was weighing failure of short segment versus the degree of anterior column destruction. So what this paper showed was that the implant failure was directly proportional to the extent of anterior comminution. So similar to the cervical paper which I spoke about earlier, which revealed the strength of the posterior column, this paper in a way reveals the strength of the anterior column. So what is the philosophy of this paper? The philosophy is thoracolumbar spine fracture fixation requires optimal load sharing between bone and implants for successful fusion. Bone fragments in comminution do not share load like intact vertebra. Opposed fragments favor and displaced fragment hinder load sharing. Greater the kyphotic correction, greater is the risk of void in the anterior column. So if you do an overzealous correction and create a big void in the front, it is going to fail. So this paper has been there in circulation for last 27 years, but still it is an evergreen paper, and has helped us in our thought processes, not with just regards to trauma, but many other pathologies. There have been some criticisms of this paper, but in spite of all that, this paper's core concept that is always strikes me whenever there is an anterior column deficit, whether it is TB spine, infection, tumor, deformity, osteoporotic fractures, any degenerative condition with a large vacuum in the disc space, I always, the cells of my body remind me of this particular paper when it comes to this. In the recent years, what has impacted me to a substantial extent is the concept of dynamic cord compression causing cervical myelopathy. So this particular concept is not derived from this particular paper. I'm not totally influenced by this particular paper regarding this concept. This is just to highlight one of the articles which also professes to this philosophy. For example, this particular paper shows a few examples such as these, where the patient post-surgically was doing worse than what he was doing before, because you can see here, this is the flexion extension MRI of the same patient showing compression and extension, and another patient here who again was much worse after surgery because of this dynamic component of soft tissue which was punching onto the spinal cord. So this is just one of the papers which believes in that particular concept. For example, this is a 60-year-old gentleman with a bull neck, who comes with cervical spondylotic myelopathy. And if you see here, he has a kyphotic cervical spine, again, which is re-emphasized on the MRI. He has multi-level compression, though severe at C3-4, but the entire alignment of the spine, cervical spine, has to be taken into account when it comes to decision-making. So, operating on such a patient from the front, doing a 3 to 3.5 level corpectomy and reconstructing is definitely an option. But why would you do this in someone who has a bull neck when you know the complications of multi-level corpectomy in the cervical spine? So an easy way to do a dynamic MRI, which shows that it is a flexible deformity. There is some degree of lordosis that can be created, which is very much which is very much realized on doing this dynamic MRI as well as the CT. So this is what we exploited. We positioned the patient in lordosis, cervical lordosis, decompressed in that particular position, and fixed him solidly from C2 to C7 and decompressed. So this is the final result. You can see in the post-operative MRI, which was done for academic reasons, the cord is migrated posteriorly. There's an abundant space created all around the cord. So this is the play of dynamics in cervical spine by applying the concept of dynamic imaging. This has helped me in diagnosing myelopathy who otherwise showed signs and symptoms of myelopathy, but had a normal looking MRI, which on forcing into dynamic flexion extension revealed compression in many patients. There are many other advantages of doing dynamic MRI. It helps in selecting levels. It helps in prognosticating a patient in terms of the space available for the cord after decompression, etc. So there are many other advantages of dynamic MRI. which I routinely use in my practice. What has again altered my management in terms of patients with osteoporosis is use of teriparatide in post-operative patients. So, if a patient comes to you with a fracture femur and if the patient has a bone density of minus 5.5 T-score, would you refuse surgery for such a patient? So then why would you refuse spine surgery for a patient who has a degenerative condition which is severely agonizing? Why would you postpone a case of degenerative spondylolisthesis just because the patient has a poor T-score? So in such a situation where you want to help the patient, there is some degree of confidence that has been built up by this particular paper, wherein it shows that if you start teriparatide immediately after a fusion, you could reduce pedicle screw loosening. Adding to the previous study is another interesting paper which is published in JBJSA a few years back, which shows that the patients who receive teriparatide post-operatively have a higher rate of fusion compared to a randomized group of patients who were not on teriparatide. So this is these two papers help us in building a lot of confidence in treating patients with degenerative conditions firsthand who have documented evidence of osteoporosis. We don't have to make them wait till they build up their bone stock, and this has substantially changed my practice. Another study which was published by us gives significant degree of confidence to the treating surgeon that irrespective of the patient being on aspirin or clopidogrel, one can go ahead with minimal access spine surgery. It was not impressed by the study done earlier, the one study which is mentioned on top, which was published a few years back. The study published by Xueller et al. Came in handy when we had already started practicing non-stopping of anticoagulants prior to surgery. It just gave some more confidence to our understanding of this particular philosophy. So such papers help in managing patients with severe hematological problems. For example, this patient had a liver failure with a shooting PT INR. He was had severe discitis that made him totally invalid, and in spite of bed rest, antibiotics, etc., he was not getting well. And these kind of these papers gave us, and our own experience gave us confidence to go ahead and treat this patient operatively. I can tell you that this patient bled as much as a normal person bleeds. So spine is a minefield. It's a big specialty. There's a huge potential for research. There are age-based conditions. There are region-based conditions. There are sex-based situations. And again, measuring of outcomes is done using multiple parameters for multiple symptoms. We have non-operative options, we have operative options, we have fusion, non-fusion options, etc. So that's why there's plenty of scope for further. So to conclude, actually there's no conclusion. Fresh knowledge will keep emerging and evolving and will keep impacting our thought process and application. The onus lies on us, here on me, to choose what is best for my patients. Thank you, ASSI, once more.